So good morning, good afternoon, everyone, and welcome to our webinar series today. My name is Sabrina. I'm a program manager and the registered nurse at the Registered Nurses Association of Ontario. It is my pleasure to be with you here today in this interactive webinar series entitled Supporting Mental Health and Long-Term Care webinar series, Severe Mental Illness. Today's webinar will focus on psychosis and long-term care, and we are delighted to have all of you join us on the phone today. Just a quick few housekeeping items before we do start. There is a chat box, as you can see. We've asked everyone to indicate where they're from and what sector they work in, and if you can hear me, even more importantly. So we will be using the chat bot throughout the webinar today to actually interact with everyone. If you scroll down, you should see a toolbar either at the bottom of your screen or at the top of your screen. There is a function called Q&A. If you could use that functionality to actually type in questions that you may have, we'd be more than delighted to answer them as the webinar goes on today. A copy of the PowerPoint presentation and the resource list will be sent out post-webinar. This will also include an evaluation link for today's webinar, as well as a recording of the webinar as well, in case you want to either listen to it again or share it with your colleagues or friends. I'm going to now turn it over to Erin Clark. Erin Clark is the president of the Mental Health Nurses Interest Group, and Erin's going to be introducing our presenter for today. So Erin, I'll turn it over to you.
Thanks, Sabrina. On behalf of your host, the RNAO and the Mental Health Nursing Interest Group, I want to welcome you to today's webinar. This webinar is one of many resources that made available by the Ontario Ministry of Health and Long-Term Care. I would like to introduce our speaker for today's presentation. Marianne Oribhabor is a corporate clinical educator at the William Osler Health System. Graduating from Lakehead University in 1997, she pursued a career specializing in mental health and addiction, working as a frontline nurse for 10 years, a resource nurse for 8 years, until assuming her current role as a corporate clinical educator. In 2018, she took a part-time role as a professor at Humber Institute of Technology and Advanced Learning in the School of Social and Community Services. She has presented to volunteer associations on mental health and addictions, as well as provided one-day seminars on mental health and addictions to community agencies. She is also a MOAB, which is the Management of Aggressive Behavior trainer with Osler. So welcome, Marianne.
Thank you very much.
Yours.
Okay, thanks everybody for joining us today. So we're going to go over an overview of severe mental illness in adults in long-term care. I want you to be able to recognize the signs and symptoms of severe mental illness, apply evidence-based interventions to support adults with severe mental illness in long-term care, as well as learn the role of the healthcare providers that work with the residents and individuals with severe mental illness. We've got some resources here provided by RNAO. It's an excellent resource. I've reviewed this and I've actually shared it amongst my colleagues. It's on mental health and addiction, a nurse educator pamphlet that's available on the website. And for more information, you can always click on the link that's here. So for today's topic on psychosis or schizophrenia, combination of both, our objectives are to define psychosis for you, as well as how to define schizophrenia. I want you to be able to understand how to communicate with these individuals that suffer from psychosis or schizophrenia, how to support these individuals when working with them, and the ABCs of behavior management. So what is psychosis? Psychosis is a debilitating mental condition when a person loses contact with reality. Psychosis alters how a person thinks, perceives the world, and ultimately how they feel, behave, and function. Psychosis may be caused by a psychiatric illness such as schizophrenia or bipolar, and it can also be caused by a brain injury, an infection, or substance use. Symptoms of psychosis can include delusions, hallucinations, disorganized thinking, and bizarre behavior. And a delusion is a false belief of something. And a hallucination is when someone sees, hears, feels, tastes, or smells something that is not there or that you cannot see, hear, feel, taste, or smell yourself. Schizophrenia is a chronic disease that affects the thinking, perception, mood, and behavior of an individual. It is considered a psychotic disorder which involves the loss of contact with reality. Schizophrenia greatly alters how a person thinks and perceives the world, and consequently how they feel and behave. About 1 in 100 people will develop schizophrenia, and men are more affected than women. There are some subtypes of schizophrenia. It also involves the inability to orientate oneself with reality, a withdrawal from social interactions, and a failure to integrate thoughts with emotions so that the emotional expression is inappropriate. The subtypes of schizophrenia include paranoid schizophrenia, and as well as those with paranoid schizophrenia can have marked catatonia. Schizophrenia has both positive and negative symptoms. Positive symptoms is what we consider is what has been added to the individual. So those would be your hallucinations, your delusions, your paranoia, preoccupations, as well as violent or aggressive behavior, excuse me, or restless behavior. The negative symptoms is what is taken away from the individual. So the ability to function, their ability to express themselves, it can be seen as their facial expressions very flat, and reduced social interactions, as well as decreased energy. Fragmented thinking is thoughts where people, they can't formulate a complete thought or sentence and have it flow logically. Cognitive defects are a defect with concentration, memory, as well as problem-solving ability. And a cognitive defect is when someone has a difficulty with their memory or has difficulty concentrating on what you ask them to do or what you are saying to them. Difficulties with speech can be seen as the individual not being able to find the right words to say to you or being able to formulate a sentence to make themselves understood. Some characteristics of schizophrenia. There's the distortion of reality. Again, hallucinations and delusions, which I've already defined for you. Ruminating about religion and philosophy. And when someone ruminates, they are thinking very deeply about the topic. They could have grandiose ideas, and having grandiose ideas, they will seem that everything is extremely important and have lots of details around that idea. Disorganized thinking, poor or incongruent emotional response, so their facial response or the emotional response is not appropriate to what is being said to them. Poor self-care, that involves their ADLs. Social isolation or withdrawn from people and or things that they've always liked to do, as well as a risk of suicide. There's 3 cycles within schizophrenia, or 3 phases that we call. The prodromal phase, which is the precursory stage before we hit the active phase. And the active phase is what is currently happening. And the residual phase is the tail end of the individual throughout the cycle of schizophrenia. Your prodromal phase is where you start to see your clients or residents losing interest in things. They're withdrawing from activities or things that they always enjoyed. They might seem easily confused or agitated, have poor concentration and unable to focus. They might have apathy, and apathy is just not really caring about anything that's going on around them. A preoccupation with delusions. And for the most part, it's usually family and close friends that notice these symptoms first, or if you are the primary caregivers, you will notice these as well. This prodromal phase can last for weeks to months. There is no set time frame on this. And after the prodromal phase, it is usually followed by a psychotic event. So a psychotic event is usually happens within the active phase, where someone is suffering from a psychosis. They're having hallucinations or delusions. Their thinking could be distorted, so they are not thinking appropriately and responding appropriately. They could have some paranoia. They might feel that people are out to get them, or that their food is poisoned, or everybody hates them. They could be obsessive in their thinking as well. They could also have some disturbances in their behavior, where you might see people starting to get a little bit more agitated or slightly aggressive, starting with verbal aggression. And during this phase is when you start to see self-care being affected, where they stop the simple things like brushing their teeth, combing their hair, and attending to their hygiene. Your residual phase is where people become very listless, which is a lack of energy or interest, or they've just got lack of spirit to do things. They'll have often trouble concentrating again on what you're speaking or telling them, or trying to instruct them to do. They'll be withdrawn from activities and even withdrawn from themselves. Their functionability will change. They may continue to get worse with each active phase as they have a recurrent breakdown with their illness. And the effects will be cumulative over time. So with each phase that they cycle through, after they become well again, they will, the phases will get longer for them to follow through with, and the phases will get longer before you start to see progression. Some supportive interventions for those that are caring for these individuals. You need to provide regular, consistent, predictable routines. And I know that's very difficult in long-term care. Sometimes you need to have quiet time and quiet space for these individuals. Try and reduce the stressors. Limit the change that happens around them or with their routines. Try and establish a trusting relationship with that individual. Ensure that there is medication and that they are compliant with their medication. And identify the early signs of relapse. You need to speak in a calm, soft voice, maintain eye contact. And when you're providing instructions or directions, make sure that they are simple for them to understand and not to provide more than one instruction at a time. And when I say to establish a trusting relationship, try and find something in common with the individual, and it could be something as simple as their favorite color or their favorite type of ice cream. Just try and find some sort of commonality ground. Ensure that these individuals have a balanced diet and are having some form of exercise within the home. Accept the setbacks that these individuals might have. It's not their fault, but it's a function of their illness. Keep your conversations and directions brief. So don't expect them to do more than one thing at a time. Don't come in and say, okay, we need you to get up. You now have to go to the bathroom, brush your teeth, wash your face, get dressed, and then go to the dining room. You're going to have to start with just, let's get out of bed, and then move to the bathroom, and step by step, take it one step at a time with people that are suffer from psychosis or schizophrenia. Try and use the words I and me, not we. So I would like you versus we need you to do something. Don't argue with the individual. I know that sometimes it is difficult not to, but try and phrase things that you understand things are difficult right now, and maybe we can work through this together, instead of them saying no and you saying, well, yes, it has to happen right now. Focus on the individual's strengths. Every individual has a strength. We just have to find it within them. If they've got family, use their family and friends or visitors as a support system. Ask them what works best for these individuals when they are in these active phases of their psychosis. And be aware of any contributing or complicating factors, whether it be a change in diet, a change in their medication. I know that sometimes the residents go out for social times, or they have outings outside the home. Just ensure that there hasn't been a complete change in the routine. And accept any little setback. Setbacks could be as simple as they are unable to perform their ADLs today the same way they could yesterday, and just support and encourage the individuals to get through the process of the setback. Some communication tips. Reduce the stimulation. Again, I know that's very difficult in long-term care as well as it is in hospitals. But people with psychosis are very easily overstimulated. And if we can try and lessen the noise and be actively aware of this, it will help you be able to deal with these individuals a little bit better. Try and remove the stimulus. If you can't remove the stimulus, try and remove the individual from the noise or from the overstimulation. Have brief conversations. Don't ask too many questions at once. I know we have a tendency when we communicate with people, we're already formulating a response to their answer or formulating the next question that we have for them or the next task that we want them to do. But just make sure that you listen completely to the individual and ensure that they have understood what you're asking and you understand the response that you're receiving. Deal only with immediate issues. So if the issue is getting them out of their room to go to the dining room, that's what you want to deal with. If they're still in their PJs, let it be. Don't try and force them to change. Just if it's them getting to the dining room to get to their meal so that they are on time and they're not going to miss a meal, it's more important than ensuring that they are dressed for the day or that they've had their shower. Sometimes we have to be a little bit more flexible. Discourage discussing feelings. I discourage you to not share your feelings or how things make you feel. If somebody is irritating you or they're bothering you, that's not the appropriate time to be telling somebody that. Just, you have a job to do, we want to make sure that the residents that are there, as well as that individual and the staff, are safe. Try not to be authoritative. You need to be firm and practical, but realistic. And when you come across as being authoritative, people will shut down, especially those with psychosis, and you will discover that they will not do what you want them to do. Don't jump ahead to the person's demands, or don't jump on the person's demands. Try and come to a compromise. There is ways that we can compromise. Don't get caught up in the person's euphoria. And euphoria is an intense excitement or happiness. Sometimes those with psychosis can be very elated or very bright and intense. And don't try to convince the person that his or her plans are unrealistic. But you need to make sure that they're safe. They may not want to, they may want to, go jump onto the subway and go on a trip. Maybe it's not the appropriate time. Maybe you can think about discussing this at a later time. There's ways around dealing with the individual's demands. Your role as a long-term care staff, we need you to understand the illness, and we need you to know that schizophrenia is highly treatable, providing that patients are following their medication regime. Get to know the individual. The symptoms vary from person to person, but if you know the individual and know that it is a symptom that they are showing, not themselves, it'll make things easier for you. Try and navigate the system for the residents. Be involved in their decision-making, and to promote cooperation and adherence with treatment. If you involve your residents in decisions that need to be made, it doesn't matter whether they have a psychosis or they've got an illness like schizophrenia, they do want to be involved in what is going on in their treatment plans and in decisions that are being made for them. A lot of these individuals are highly intelligent. We have a tendency to forget that. And we just need to make sure that they understand that we're working together, not for them. Include family members in caregiving if at all possible. Sometimes residents will not want to have a bath on a certain day or be bathed by certain members of the care team. That's okay. Try and find a compromise. And maybe if they're more willing and able to attend to some of these things that you're needing them to do, if a family member can be present, that's okay, especially if it's considering compliance around medication. You need to advocate for your residents, for their safety, and to ensure that they are being treated the way you want them to be treated. How to monitor people with schizophrenia. I like to look at what I call the 7 Ds, that you want to make sure that it's not dangerous to themselves or others. You want to make sure that they're not distressing. Their symptoms are not distressing to that individual or others around them. We want to make sure that they're not disturbing others, whether the hallucinations and delusions are disturbing to others or themselves. Unfortunately, they are disturbing to the individual, but we don't want them to be disruptive for other residents around them. Take direct action. So act on we want to make sure that they're not acting on their beliefs or their command hallucinations. And a command hallucination is when it's usually an auditory hallucination where they are hearing a voice telling them to do something, whether it is to harm themselves or somebody else. We want you to be definitive. So monitor their insight. People with schizophrenia will be able to tell you when they are starting to decompensate. They often won't because they know what the next steps is. Usually it becomes hospitalization, but they do have insight into their illness. They'll have decreased independence and they will become distant in social situations. Routines are critical for individuals with psychosis or schizophrenia. They like predictable settings with rituals and repetition. Redirection is often required. If you can diffuse restless individuals with tasks such as simple as folding towels, offering them to help in the dining room, whether it be setting tables or cleaning up, having music as a distraction or a redirection is great, or if they've got a favorite TV show or movie they like to watch. Reorganization of the environment. It can be sometimes as very simple as changing the environment for the individual or changing where the individual is in the environment, whether it be a concrete task or with very small steps. Sometimes if you have a resident with a psychosis or schizophrenia that is close to the door into the unit or the area, it's very noisy, people are in and out all the time, or if it's close to a dining room, that might be too much stimulation for them. Just a matter of reorganizing where their room is. Sometimes it can be that simple. Your ABCs of behavior management. Your A stands for antecedent. Your B is your behavior, and your C is your consequence. And I'm going to go into these in more detail in the next few slides. So you want to be able to control the stimulus or the antecedent of the behavior. And some antecedents may include things like the environmental factors. Again, like I've said, the stimulation, whether it's noisy, too much light, or the lights are too bright. Internal factors can be a reason for people to have an outburst. They could be hungry, they could be tired or thirsty, or it could even be a side effect of a medication that they're currently taking. You need to consider cognitive factors as well. Have they misinterpreted the message that you are sending them? Are they misreading your nonverbal signs? And it's well known that with communication, 90% of communication is nonverbal, and people will go by your nonverbal communication over your words. If your words and your nonverbal don't match, that's when you have issues. And like I tell anybody I speak to, it's never my words that get me in trouble. It's always my facial expressions or my body language, because it doesn't match what I'm saying. You need to adjust to the environment. Make it easy for the person to do well. Try and eliminate or decrease known triggers of the unwanted behavior. And you need to remember that it's easier to alter the environment than to change a person. If you can't alter the setting that the individual is in, anticipate the outcome that you might have and attempt to minimize the negative response and maximize the positive one. There's always a positive and a negative response, and you just need to be able to reframe things so that you can find that positive response with the individual. With redirection, it's a method to disengage one from the negative behavior to be a more productive, positive behavior. We have a tendency to lecture or scold people when they've done something wrong, and that's been taught to us because we lecture and scold little ones, and sometimes we have a tendency to do that with people our own age or older than us. You need to be able to redirect and engage them to another task or train of thought. So if a resident is becoming visibly upset with another resident in a dining room, try and redirect them. You know, would you help me check the rooms to see if anybody else has missed their meal? Try and just remove that, and just that simple redirection of the individual, even if you don't get them very far, you just get them out of the dining room to get them calmed down enough so that they can re-enter the dining room and sit down to have their meal. Sometimes that's all it takes. Redirection may assist also with perseveration, prolonged repetition of either a verbal phrase or a physical movement. So if someone is continuing to repeat a phrase or continue to do physical movements that you need them to stop, sometimes redirecting them is easy to do. With poor judgment, you want to engage the at-risk or socially inappropriate behavior. So sometimes these individuals will have poor judgment due to their cognitive issues that schizophrenia and psychosis can have. So you want to be able to redirect them right at that time with that behavior. Sometimes they have a lack of emotional control. They might have sudden mood changes. They can easily get agitated and upset. And sometimes they can go from verbal aggression to physical aggression. So you want to be able to try and reduce the chances of them getting to that physical aggression stage. So redirection can often help with that. Oftentimes they're unaware as to how their behaviors are affecting other people. And once you've redirected them, got their attention away from what they're doing, if you point out that, you know, their loud voice has scared another resident, sometimes that's enough to bring them down a little bit and to redirect them to something that you want them to be doing. You need to constantly reassess. Sometimes some of these illnesses can have a physical effect on them. You also need to reassess their memory, reassess continence and hearing, as well as visual acuity. If someone can't hear properly or see properly, that can cause them to have a relapse quicker. Or if we're not toileting individuals, or if there's a continence issue that, believe it or not, that can affect an individual with schizophrenia or psychosis. And we sometimes forget about those simple little things. Again, reduce the overstimulation in an environment. If they're attending a group and the group is too much stimulus for them, Sometimes you might just have to have them be removed from the group, but maybe you can find a quiet activity for them to do. Refrain from arguing with the resident, especially around a hallucination or a delusion. When you argue with people, you tend to have we have a tendency to match their tone for tone, and we will then end up having, you'll end up having more issues than being able to resolve the problem. And once they have settled down and calmed down, talk to them about the experience they had. Ask them questions, find out what their triggers were, and maybe if that's put in a care plan, if we know something triggers an individual, if we can reduce that trigger, you will have better outcomes with your residents. Confabulation are false statements not made to deceive an individual, but often an individual has taken real facts and distorted them. And things that you will see when someone is confabulating is the recounting of a distorted or completely fabricated story. So an individual has completely made up a story, or they believe that the story is 100% true. Some strategies around when individuals are confabulating, without confronting them, retell the individual the structure to retain the factual part of the story, just so that you are not, again, arguing with the individual, but that you are trying to find the root cause of what is going on. Some strategies that you can use with your residents: develop a positive rapport with the person. Know that the nature and the consequences of the person's illness. And again, I can't stress it enough that the symptoms you are seeing, they're symptoms of an illness. They're not the individual. And sometimes if someone is in a complete psychotic state, they will not remember the behaviors that they've had. And when you remind them of the behaviors that they were presenting, oftentimes they're very ashamed or they feel very badly about what they have done. You want to learn as much as you can about the person's impairment. Find out what their strengths are and work with those strengths and their interests as well, and know what their limitations are and know what their triggers are. When we know what triggers and limitations our individuals have that we're working with, we're able to avoid problems, and we can reframe things so that we are working with their strengths. And if one thing fails, try another. Unfortunately, it can be just sometimes trial and error. And it's very important to know what triggers you and your own anxieties. So not everybody is comfortable working with individuals with mental illness. And unfortunately, there's 1 in 4 that is affected with a mental illness. So it's unavoidable at this stage of the game in healthcare. But you also want to avoid power struggles. So if you know something triggers you, try and avoid that situation, and let your colleagues know. Sometimes we have good days and bad days as healthcare professionals, and we can't always deal with the situations day in and day out, from one day to the next. Behavior consequences and strategies. Sometimes these individuals will be disinhibited, so they have absolutely no control of what they're doing or why they're doing it. They can be seen as very impulsive. And again, this disinhibition and impulsivity comes with knowing what triggers these individuals and what their limits are. You might observe someone with complete disregard of social rules, or they might have very impulsive acts with their speech. They could have severe mood swings, or they could be happy in one moment and very irritated in the next. And if you look back at the situation, you will find out that there was some sort of trigger or stimulus that was causing that. Some strategies for you guys to use positive reinforcement. If a behavior is appropriate and they're doing something great, they're doing something well, they're helping someone out, use that as a trigger. Use that to support the individual. Keep cool and don't overreact. Provide physical as well as verbal cueing. Sometimes it's they They understand the motion of brushing their teeth or brushing their hair, but they can't connect the words with the action. So if you use both verbal and physical cues at the same time, it can be beneficial. Redirect the individual back to an appropriate behavior or what you're trying to, the task you're trying to accomplish. Eliminate, again, or reduce the stimulus that brings on that behavior. And again, that is being able to know your residents really well and knowing, having a good care plan in place. Social dysfunction that you might observe, the misinterpretation of social cues. They might have limit or faulty interpretation of other people's actions and words. Things for you to consider: speak clear and concise. Again, not too many instructions at one time. Use the positive reinforcement for things that have been done properly. Provide feedback to the individual how the behavior, again, is affecting others and even how it's affecting you. Nobody likes to be yelled at, and you can clearly tell individuals, please don't yell at me, it's not nice. It's okay. You're being honest, and sometimes that's as much of a distraction as that individual might need to stop the behavior. When you see someone that is very angry, what you might see is some swearing, yelling, hitting of things or people, even destruction of property. Yes, this can be scary for people in long-term care, for the caregivers as well as the other individuals and residents that are around this. Some strategies for you: redirect, again, to appropriate behavior. It's okay to say you need to stop hitting, you need to stop yelling, and don't take it personally, which oftentimes we do. If someone is yelling or swearing at us, we have a tendency to take it personally. Again, remember, it is part of a symptom, it's not the individual. If there's a attention deficit or loss of concentration, you might see the inability to stay on track, a partial understanding of the task, or they might change the topic because they don't understand what's going on. Again, using verbal and nonverbal cues can be very beneficial, as well as minimizing your distractions that are going on. So try not to have conversations with your colleagues if you're both providing care for that individual. One person talk directly to the individual and only one person providing the instructions of what you want them to do. How you can support somebody with a delusion. Again, just to clarify, a delusion is a false belief regarding a person, object, or self. And delusion is one symptom of that a psychotic person might have. You don't want to debate about the information that's being presented to you. You want to avoid confrontation. You want to provide positive responses to a non-delusional information. How you can support somebody that is suffering from a hallucination, and just to clarify that again, a hallucination is someone that is seeing, hearing, feeling, tasting, or smelling something that is not present. So no one else can hear that but the individual that is suffering from the hallucination. You might want to ask what they're responding to. And I caution you to say, don't say, are you hearing voices? When I've done that, they say, yes, I'm hearing your voice. So you need to, if you want to know if they're hearing a voice other than yours, are you hearing something other than my voice right now? Inform them that it's part of their illness and that you're there to help them. Note when they're distressed and what was happening prior to that, that individual getting distressed. Never deny how they feel. Help them through the stress. An individual that suffers from a hallucination, it is very distressing for them, especially when they are seeing things that are not there on the walls, or crawling on themselves, or hearing voices in their head that are telling them to do things that when they're in a well state, they know are wrong. Keep to short interactions just to meet the immediate needs of the individuals. Don't get into in-depth conversations with them. These strategies are very good for supporting both individuals, both suffering from delusions and hallucinations. Again, changing the environment by reducing the stimulus. You can't change the person or the illness, but you can change what's going on around them. Effective, clear, concise communication. Active listening. Understand what's being said to you by the individual. Sometimes we have to clarify to ensure that the message we are receiving from that individual, that we've perceived it appropriately or the way that they intended. We want to accommodate the physical and cognitive disabilities or the impairment. And sometimes if things have to change in their environment, whether it's a new service, new technology, new people moving in, a change in staff, sometimes we have to prepare these individuals for these changes in advance. Sometimes we don't always know when these changes are going to happen, but if you do know, if you can prepare the individual that there is a change happening and that they understand it, you will be better off. Some routines to stick to. Stick to predictable settings that have sometimes repetition or rituals with them. Again, redirect them. Diffuse the restlessness with tasks such as exercise, offering food and music. Reorganize the environment sometimes. Again, I can't stress that enough. It is, these are great supportive strategies if you can implement them in your workplace. Some things I want you to avoid. I want you to avoid challenging the actual individual or the behavior that is happening. Nobody likes to be challenged, whether you have a mental illness or not. Nobody likes to be challenged in what they're doing. Don't corner the individual. Allow them space. If they need space to vent, allow them the space that they require. Sometimes it's setting up a quiet area or a quiet room, maybe with different things in it for them to utilize, for them to de-stress with, or just to be able to have an area where they can just pace and walk around. Avoid raising your voice or criticizing the individual or the behavior. Again, avoid taking things personally. The behavior is not directed at you. Avoid situations that can become very chaotic for the individual. Don't be judgmental or argumentative. Offer choices that are reasonable. And if you offer choices, they might not like the choices, but they will figure out the choice that they want to do. Inform them of what they are doing at the time, especially if it's personal care. So if you are going in to provide them personal care, just do a quick assessment of that individual to make sure that they're not responding to some sort of internal stimuli, whether it be a hallucination, because if they're responding to something right away, they might perceive you as being a threat to their environment and themselves. So always let them know what you're doing in advance. Remain calm and reduce stimulation. Redirect individuals and behaviors if you can. Sometimes it's not always possible. Again, don't challenge, and ensure that the safety of everybody is utmost paramount. Not only the safety of the residents or the individuals around this person suffering from a psychosis or schizophrenia illness, but also the staff. So make sure that you talk to your colleagues and ensure that the environment is always safe that you are working in. Thank you very much.
All right, thank you for that excellent and informative presentation. Now over to Sabrina for questions.
Perfect, thank you, Aaron. If you do have questions, please do type them in the Q&A pod that's located on the bottom of your toolbar. We do have a few questions right now, Marianne, that we would like to ask you. And so the first question comes up. So there's a resident with depression, dementia, delusional disorder, and anxiety disorder, is currently not receiving any medications to assist, and is noted to be declining and becoming anxious, agitated, and physically and verbally aggressive. The POA does not want medications. How do we advocate for the resident?
That's a tough one, especially when the POA doesn't want medications. I'm wondering whether it's education that is required with the POA to let that POA know that they're declining. They are declining due to their illness, and maybe it's they're going to physically decline, and we don't want them to physically decline. And sometimes just a low dose of medication can be helpful to increase appetite and get them back to their functioning that they are. When they have got a dementia as well as anxiety and delusions, delusions do come along with dementia, and it depending on the type of dementia, it's difficult to distinguish or differentiate those. If someone is highly anxious, they're not going to be able to function properly. So maybe it's just a low dose of medication to reduce that anxiety enough that they are able to eat properly and function at a baseline level.
Thank you. The next question is, what if redirection is not possible? A violent resident who lashes out. What interventions would you suggest at that particular moment?
Again, keep everybody safe. Keep yourself safe. I highly recommend that long-term cares get some sort of programs in on how to deal with anxiety, which can then proceed to physical aggression. So things like nonviolent crisis intervention training, management of aggressive behavior, anything that will be able to give you more tools in your toolbox to be able to deal with these individuals. If you are able to contain an individual just long enough to get medication into them, and sometimes it's a physical containment in a very safe way with your colleagues working together. Again, long-term care, I understand. I worked in it for 10 years, over 10 years, so it's not an easy thing to do. But sometimes if you've got the background and the education on how to contain a situation physically, to get medication into the individual to keep everybody safe, as an immediate response, again, or get the immediate response dealt with, and then have them seen by a physician, whether that be the emergency room or the physician within the building. But you need to keep everybody safe. And I know a lot of times it's a 911 call and they come to the emerge department, and then they are settled here and they get shipped back to the long-term care, and there's been no changes. But again, it's a conversation with the POA, ensuring that everybody's on board. And if you can get the resident well enough to participate in their own care, that's what you want.
Awesome. If you do have another question, please do type it into the chat pod at this point. There is one final question. What can be stressors during an active phase of schizophrenia?
Anything can be a stressor, whether it's the color of someone's top. Sometimes it's simple changes. I often wear my contacts, but if I'm stressed or I'm doing a lot of computer work, or if I was on the night shift, I wear my glasses. And just that simple change sometimes would set a patient off. So if somebody is in an active phase and responding to something, you need to figure out what changed. If the behavior wasn't that way an hour ago or the day before, what's different in the environment? What's different with the individuals? Is it a different group of staff in? The slightest change can sometimes be just enough of a trigger to set somebody off.
Awesome. Marianne, actually, I have one question to my
Sure.
own. If you had to give us one piece of advice or one tidbit to be able to enhance their abilities to support individuals living with mood disorders or with psychosis, would you be able to articulate what that might be?
One thing, never challenge them. Never ever challenge them. I learned that very early in my career. You sometimes have to agree with what they're saying, but don't challenge what they're saying to you. So, oh yes, I understand that you're telling me this great story. Oh, great. Yes, you're the president of whatever organization. That's fabulous. You must have had a a great job when you were there, but never challenge them. And because when you start to challenge them, you're getting into their personal space. So maintain a safe distance, a 4 feet distance when you can, if they're in a state where they could potentially get aggressive. That way you are able to react and keep yourself safe.
Fantastic. So on behalf of our participants, on behalf of the Registered Nurses Association of Ontario, on behalf of the Mental Health Nurses Interest Group, we'd really like to thank you for spending your time here with us today. I think you've provided a great foundation of knowledge, as well as a lot of great tidbits and tips of advice that we can actually follow. So it's a very practical webinar, and I'm sure our participants can agree that it was a very fantastic one.
Great, it was my pleasure.
Just to follow up, our next webinar in this series will be on December 5th. It is Marianne again who will be presenting. Then we will be presenting mood disorders in long-term care. So now that our time is up, I want to thank everyone for being with us here today and participating actively in this webinar session. And again, if you can help me, please thank our fantastic presenter today. That would be fantastic. A lot of times I use fantastic in one sentence. Following today's presentation, you'll be sent an email with a link. In this link, you'll find the evaluation for today's webinar. Upon completion of the evaluation, you will receive a certificate of attendance for today's webinar. And you will have a 2-week turnaround period to actually complete that link in that webinar. We really highly encourage you that you please complete the evaluation, because that really helps us understand what was good from today's webinar, what could be improved, and as well as really helps us in planning future webinars that would address your needs and your concerns and your opportunities as well. We also hope that you will join us back on December 5th. Registration link will be open. What will also happen is Tanya will send out a resource link. Marianne has been very kind to provide us a link of the references that you've seen on the screen before that provided the supports to the PowerPoint that she's presented with us today, as well as other references and links that she claims that she feels are very valuable for us to have. So you will receive that also with the evaluation. And we hope that you will join us on an upcoming webinar series. And for more information about our program, please do check out rnao.ca on the events page. Thank you for joining us for today. Have a great day. Bye-bye.